I'd like to introduce our speakers this morning. Maribel Gonzalez is a clinical educator with the Florida Caribbean AIDS Education Training Center, and she has 10 years in HIV/AIDS care. She's dealt mostly with adolescents and adult care, and she comes to us this morning from the Coral Gables office, and so she's going to join us by the miracle of the internet, as well as Saniyyah Mahmoudi, who is also an advanced registered nurse practitioner. And Saniyyah has 19 years of experience in HIV/AIDS care. She has worked as a pediatric nurse practitioner and currently is working as an adult adolescent practitioner. So I welcome both of you this morning. They're going to do some tag teaming during this presentation, and I know that you will all be very encouraged and educated on the subject of preconceptual counseling.
Thank you, Mary, and good morning, everybody. So we're going to go ahead and start the presentation, and our objectives for today, we're going to, upon completion of this program, participants, you guys will be able to epidemiology and factors influencing conception in people living with HIV, describe behavior changes that are related to family planning and conception, compare resources and tools to frame patient discussions around conception, identify risk reduction strategies, as well as able to explain methods for reducing risk of vertical transmission. And then finally, we're going to be able to list options for maintaining maternal health. So I'm going to start the presentation by kind of presenting two cases, and then we're going to be discussing them at the end of the presentation today. The first one is a 35-year-old newly diagnosed HIV-infected male. He comes to clinic accompanied by his HIV-negative wife. His viral load initially was 9,500 copies, and his CD4 350 cells. This patient had no insurance. He was just a Rhine-wide patient, and his wife was also uninsured. And both of them, they discussed with myself that they would like to have a baby. So the wife wanted to conceive. So what advice are we going to give them? The second case is for a 34-year-old Burmese refugee. She just moved to Jacksonville like a year ago. She's on a tripla. Her viral load is less than 20 copies, CD4 520 cells. She's doing fine, but she mentions that she just got married, and she and her husband are planning to have a baby. Husband is not infected, so what advice would we give her? And we're going to start our presentation.
Thank you for the wonderful case presentation, Saniyyah, and thanks for the introduction, Millie. So let's get started by talking about a little bit about the epidemiology of HIV. In 2013, according to the World Health Organization, there were about 35 million people living with HIV. And according to the Centers for Disease Control, in 2012, there were approximately a little bit more than 1 million people living with HIV in the United States. So let's break down the numbers a little bit more. Out in the United States, 1 out of 4 people living with HIV are women. So we can talk about women and women that are living with HIV. And out of those 25% of the about 1 million people living with HIV in the United States, 80% of those women are of childbearing age. But we must not forget about the men that are living with HIV, because they are, while they may not be our patients, they are also affected by the disease, and there are about 140,000 HIV serodiscordant heterosexual couples, and that means that one patient, one of the couples is HIV positive and the other couple is negative. And it's important because these couples will want to, may want to have conceive a pregnancy. When we think that in overall, more than 1/2 of all the pregnancies in the United States are unintended, that just brings to light more the importance that as healthcare providers or as being part of a healthcare team, we need to also include comprehensive family planning, and we need to include preconception screening and preconception counseling as part of the care that we provide. I'm going to go over a little bit of the history of preconception counseling in HIV. When the epidemic first started, before 1991, women who were living with HIV had about a 25% chance of delivering an HIV-infected child. Those were huge numbers at the time, and it was a time when we didn't have really good medication. We didn't have any medication to treat this condition. So most healthcare providers were recommending bilateral tubal ligations for women. It was, that was the culture at the time. That was what was, when you weighed the risks versus the benefits, the risks of having a bilateral tubal ligation versus the risks of having a potentially HIV-infected child. The benefits far outweighed the risks, and that's what was done before 1991. Then the very first medication that was first discovered for HIV, in that time period of between 1991 and 1993, when zidovudine was introduced, we found out that it reduces the mother-to-child transmission to about 8%. So that was a huge discovery. Going from having a 25% chance of having an HIV-infected child to an 8% chance of having an HIV-infected child, that was huge. And that's when a lot of the recommendations came out for zidovudine, or AZT, as it is known, as far as the recommendations to prevent the having an HIV-infected child. Lastly, let's talk about the time after 1993, the era of highly active antiretroviral treatment. That era brought forth with it the ability to reduce perinatal transmission, or the ability of reduce when there is a mother living with HIV and she's going to have a child, that you can prevent the transmission of HIV up to, and some studies say 98%, some studies say 99%, but up to 99% of the time. And this is in women who have very, very, very good control of their viral load. Most of the studies counted that viral load as being under 1,000. And we know that we can get now viral load to where we know that it is, less than 48 copies per milliliter. So this is just a little snapshot of the timeline of what happened and how we can now prevent almost 100% of the transmissions in the perinatal transmission. Maybe as healthcare providers, or maybe as part of a healthcare team, we are aware of that history. Some of us may not be aware of that history. Some of us may be newer to HIV and didn't know what it was like in the beginning and how far we've come. And many patients also don't know the history. We'll have patients that don't know the history and don't know how many options there are nowadays. There was a study by Finocchiaro and Kessler et al. And in that study, they talked to patients and they asked them how many of them discussed their desires to have pregnancies to achieve a pregnancy with their HIV provider. And they found that in the people that they talked to, only about 25% of them talked to their provider about when they wanted to get pregnant. So that means that about 75% of the people that desired a pregnancy had not talked to their HIV provider about those desires. And these 75% of people that they talked to that did not talk to their providers about their pregnancy desires, they actually tried to conceive, without having that conversation with their providers. And even more importantly, it wasn't like they didn't recognize the risks. They knew the risk. They knew the risk to their child, and they knew the risk to their potentially negative partner. But their desire to achieve a pregnancy was it was so important to them that, this is the risk that they decided to take. There were 3 emerging themes out of that study. And when they talked to these patients, some of the themes included that they didn't know that the provider could guide them in terms of how to achieve that pregnancy. They didn't know that was available. They also said that there were certain characteristics about the provider that influenced their communication with that provider. And they also talked about how confused and the concerns they had about how to conceive in a more safe manner. So let's keep these in mind as we move forward through with the webinar. And Saniyyah is going to be talking to us about screening patients for preconceptual counseling.
Okay, thank you, Maribel. So basically, I just want to go into screening. Any woman that is desiring to get pregnant needs to have some preconception counseling if they are infected or not infected. And the goal of it is always to keep the woman healthy, make her kind of ready to conceive, as well as, optimize her health and the fetal outcome, have a healthy baby at the end result. So that's what preconception counseling is done for, and for infected or not infected women, and for partners as well. So finding risk factors that can be reduced prior to pregnancy and during pregnancy is an ongoing, plus education and looking at the needs of the patient and trying to meet the needs for the patients are as well as included in that. So HIV-affected couples, why do they want to have children? It is their right to have children, and it gives them purpose for life and regain sense of womanhood and sexuality. It is, this is the normal life. Everybody, life continues. Everybody wants to conceive and have babies. So discussing pregnancy with patients should be an ongoing event. And especially when you have serodiscordant couples, you really want to avoid the risk of transmission of HIV between the partners as well as from the mother to the child. So that's the ultimate goal. And preconception counseling is usually an ongoing event, like I mentioned. Should be brought up during office visits. It should be integrated in the care of the women as well as the couples. And it should be integrated into the discussion that the case managers have with patients. And I will also talk about that in a little bit. So screening women and of childbearing age and their intentions of getting pregnant is really important. Talking to them about preparing themselves, for conception, One of the things that needs to be talked about is disclosure between the partners in serodiscordant couples to disclose to the other partner that they have HIV. So this should be done before conception. The women should start on vitamins, stop smoking. If there's any drug or alcohol or tobacco use, that should be also stopped. So you know, we need to work with the women that is thinking about conceiving before they conceive. And they can use contraception until all of these behaviors are adjusted and are you know, kind of dealt with and achieved. Also, immunization status of the woman is very important. So in general, the whole health assessment of women, as well as mental health, if they have any mental health problem, depression, bipolar, all that need to be addressed before, you know, the woman conceives. So the role of the case manager is one of the most important roles in my opinion, because the case managers have an ongoing relationship with the patients. They visit them at their home, or they touch base with them all the time. The patient is open with the case manager and talk to them about things that they don't discuss with their provider. So the case manager should be very very in tune into asking the women or the couples, is there any intention of having a baby? And one of their questions saying, have you been thinking about having a baby, or have your partner been pushing having a baby? So the question can come up. And then also the nurses in the clinic, also they have very good reports with the patients, as well as support staff like peer navigators. Anybody that have a good relationship with the patient should be asking the question to these patients. And care for the couple should be dealt with in a multidisciplinary team fashion. There should be constant communication between the provider, the PCP, the HIV specialist, the psychologist or psychiatrist, medical case management, the dietitian, and the maternal fetal specialist. So there's a whole team, a multidisciplinary team that should be involved in the care of pregnant women, as well as HIV infected individuals. If the woman is HIV infected or her partner is HIV infected, you know, an HIV specialist should be involved, as well as for medications and other things. So I'm going to be talking about. So what are the options for conception? I wanted to present a couple of facts that are really important to keep in mind. Is that the Americans with Disability Act supports the right of couples who are affected by HIV to receive assistance with their reproduction. So you cannot tell them that they cannot have a baby. So you would need to assist them in getting the right care and the right, you know, reproduction means. Second, evaluation counseling should be provided to determine eligibility for treatment for all couples. And there is a risk of transmitting the virus to the unaffected partner through intercourse, even if the infected partner has undetectable viral load. And basically, there's a lot of research on this subject. And one of the research mentioned, you know, looked at patients and their HIV in plasma, as well as in the genital tract. And those two are two different compartments. So if you have an HIV infected patient with an undetected viral load, it does not mean that they are not shedding in the genital area HIV virus. And also, some of the research mentioned that even if the HIV in the genital tract is undetectable, still there is no zero chances of transmitting the virus, because what happens, there are some viral load blips that happens in the genital tract. It could be subclinical and unsuspected inflammation that occurs. Maybe, for example, like asymptomatic shedding of the herpes virus, or the woman getting like a bacterial vaginosis or something. And that blip increases the viral load in the genital tract and puts the other partner at risk. So there is no zero chance of transmitting the virus, but it's always recommended that the patient who is infected be on medications and maintain an undetectable viral load. And I'll mention that also in a little bit later. So in males, just to mention that the seminal fluid and the white cells in the semen carry the HIV virus, but the sperms usually do not carry the virus. In females, the follicular fluid surrounding the oocyte or the oocyte itself may contain the HIV virus. So the recommendation has always been is to reduce viral load in the infected partner. And one of the studies, the HPTN-052 study, it was a randomized, humongous study that was done overseas. 50% of the subjects were from Africa, but they looked at early treatment with ARVs versus for patients who have CD4s 350 to 550 versus waiting later and starting ARVs for the infected patients. And they found that the people who started ARVs earlier, you know, they were healthier, as well as they did not transmit the virus as the other people who waited longer to start the ARVs. And so reduce the non-infected partner exposure and susceptibility to infection is the recommendation, and to discuss available scientific evidence and risk reduction strategies for both the patient and the partner to provide a basis for informed consent. So when you sit down the partners and discuss with them, you are serodiscordant couples, and these are the chances of infection, and these are the ways to prevent transmission. It's just you're getting some informed consent from the patients, that they understand what you are saying. And if they get infected, unfortunately, something else has happened. But explaining to them is very, very important. Prior to conception, doing a medical assessment on the women is very important. If the woman has any STDs, that needs to be treated before she conceives, because having STDs increase the chances of transmitting the HIV virus between her and her partner. Look at her physical health and her mental health as well. Antiretroviral treatment should be started for HIV-infected patients to reduce their viral load to undetectable level. Avoid teratogenic drugs for HIV-positive women. So somebody who's going to get pregnant, we avoid starting them on a medication such as efavirenz-containing regimen because of that teratogenic effect. Adherence to therapy is also important so that they don't have a viral rebound. Use of PrEP for the uninfected partner, and Maribel is going to touch base on that later during this presentation. Preconception evaluation and counseling is ongoing, and fertility assessment is also important. And I wanted to mention that because, you know, patients who have AIDS diagnosis at one point, like for males, that can really affect their sperm motility as well as their sperm count. That's what's written in the literature. As well as for females, if they have HIV for a long time, HIV itself or having STDs, multiple STDs, can cause some tubal disease, and they might not be able to be as fertile as they should. So if you have a serodiscordant couples, so let's say the male is HIV positive and the wife is negative or the female is negative. The goal to prevent transmission, of course, is from the female, to the female partner who is negative. So the options for this couple, if they present to the clinic, would be donor sperm from an uninfected male. Next could be intrauterine insemination. And this is done through sperm washing because the male has a positive HIV. He's HIV positive. So there will be sperm washing and then transferring of the virus-free sperms into the uterus, into uterine cavity at the time of ovulation of the female. And this is a low-cost procedure. It costs around probably $250 per sperm washing event. And then there is, of course, intracytoplasmic sperm injection, which is very high cost, and this is also is IVF. It's very, very high cost, around $12,000, $13,000 to have it done. And basically, it's done in the lab. There's a lot of procedure that gets done with this before. So you have, there is, the woman has to be given some ovulation, induction medications, collecting the eggs from the woman, putting the sperm in, injecting the sperm into the ova, and then carrying the embryo back into the woman, as well as checking hormone levels and all the gonadotropins and other hormone, LH, and everything else on the woman. That's why it's very costly, but it is safe, and some people that can afford it, I think the recommendation is to go with IVF with intracytoplasmic sperm injection. So what if the female is positive, but the partner is negative, the male partner is negative? So the goal is to prevent transmission to the male, of course. In this case, usually you can, recommended is intrauterine insemination during ovulation. So so what happens, the woman can find out when she's ovulating by checking, like using some ovulation kits, or doing a temperature chart and finding if there's a surge in temperature that she's ovulating at that time. And within the 24 hours of the LH surge, then the male partner can ejaculate into the condom or into a cup, and the semen could be aspirated in a syringe and injected in the vagina of the woman near the cervix. And the other option would be, of course, in vitro fertilization. So the CDC really recommends for serodiscordant couples to use PrEP to decrease HIV transmission, treat the HIV-positive partner with HAART to achieve undetectable viral load, time the unprotected intercourse to ovulation only, and the rest of the time the couple really have to use condoms. Screening and treating both partners for sexually transmitted diseases, continue safe sex practices like we mentioned, and use assisted reproductive techniques if possible. Natural conception in discordant couples, it's at reduced cost and to improve autonomy of couples. Basically, the American Society of Reproductive Medicine estimated the rate of HIV transmission is 1 per 500 to 1,000 episodes of unprotected intercourse. The rate increases if the HIV partner has a high viral load, or if either couples have genital infection, inflammation, or abrasions, or some sort of problem in the genital area. One study reported that there were 4.3% seroconversion rate. However, this study, they found out that people who converted, they were not consistently using condoms. So it wasn't really a very good study. There are other studies that have reported 0.01 to 0.41% seroconversion per act of unprotected intercourse. One study reported by Hughes and his colleagues, it was a prospective study of 3,297 couples, and they had an 86% HIV transmission rate. They adjusted per act risk, that's what they reported, for unprotected male to female was 0.019, and the risk rate for unprotected female to male was 0.010. However, they found out that the patients who got infected, it's because of increased viral load and a partner, or because of STDs. And the STDs that were they were mentioned specifically were herpes, number one, trichomonas, and then they mentioned other STDs as well. But trichomonas, bacterial vaginosis, urethritis, cervicitis, as well as herpes, where especially herpes was number one. For seroconcordant couples, and concordant means that both are infected. So what are we gonna kind of advise them to do? First of all, both of them need to be treated with HAART and get their viral load to undetectable level and get their CD4 above 500. I think that will be the goal. And then if the female partner has a resistant mutation in her profile, then we use intrauterine insemination. If the male partner has a unique mutation to HIV mutation, then use sperm washing or donor insemination. Prevention is very, very important. Like we said, we want to prevent HIV transmission between partners as well as from the woman to her baby. So being on HAART therapy and virally suppressed is very, very, very important. And HAART therapy for HIV positive women who are pregnant during pregnancy is very important, and keeping their viral load undetectable is extremely important. And the HAART therapy that gets selected, make sure it's usually looked at as how effective it is, what type of virus the woman has, any mutations, and choose a regimen that is optimal for that woman, that is an effective medications. As well, if they have any other infections like hepatitis B, there are certain ARVs that we need to give if the woman has hepatitis B. And having immunity to hepatitis B is recommended, so immunization before she gets pregnant is important. Avoid teratogenic drugs. And it's also highly recommended to educate the couples on signs and symptoms of acute retroviral syndrome, and educate them also that if the negative partner shows or experiences any acute retroviral syndrome signs and symptoms, they need to see their provider right away, as well as testing for the unaffected partner should be on an ongoing basis. They need to be using, like I said, condoms except for the time of conception. If there's no other, they're not going to use any in vitro fertilization or anything else. But if they do have sex without condoms, and our patients do that without telling us, then we really need to treat the other partner as if they are exposed to HIV, and be kind of tested on a regular basis, HIV tested. At Maribel is going to be talking about pre-exposure prophylaxis.
Thank you, Saniyyah. So now we've gotten to the point where let's say you have a serodiscordant couple, and because of the cost, because maybe of lack of insurance, maybe because of the part of the state or the part of the country where they live, their options have been reduced to more of a natural planning of a pregnancy. But Saniyyah had explained to us that PrEP is recommended by the CDC, and it is exactly in those cases that I just described. Couples that maybe can't afford some of the more expensive methods of planning a pregnancy, couples that are maybe in a more rural area, specifically more of the couples where the female is the one that's positive. CDC recommends the pre-exposure prophylaxis because that can further reduce the risk of transmission from one partner to the other. And PrEP, or pre-exposure prophylaxis, is a relatively new method. It was approved by the CDC in 2012, and it is for treatment for the person that is negative, treatment for the person that does not have HIV infection. And adherence, we will talk about it a little bit more in the slides that are following. But those of us that are used to seeing patients and providing care for patients that are living with HIV have a lot of experience in discussing adherence. And so this is where we also need to be discussing adherence with the HIV negative partner. So to be eligible for pre-exposure prophylaxis, that person must have an HIV negative test. And there are other tests that should be offered before this prevention method is offered. And those tests are usually repeated about every 3 months during the time that the person is taking PrEP. So in July of 2012 is when the medication, it's a one pill that's combined with it's two medications combined in one pill. The medications in that pill are tenofovir and emtricitabine. It is marketed as Truvada, and it is a part of safer practices when it is used in combination with reducing other risks for adults that are at higher risk, which would be the different scenarios that we've been talking about throughout this webinar, where they're trying to conceive a pregnancy, one couple is HIV infected, and the other part of the couple is HIV negative. PrEP is approved and it is recommended for sexually active adult MSMs, and in the context in which we have been using it for this webinar is for heterosexually active men and women, and more specifically also for those that are trying to conceive a pregnancy. This slide describes the different studies that were performed. Some of them were stopped early, and these are using different types of medications. So I really want to point out and focus the one that has been approved by the CDC. That is, you'll see on the second line of the chart, you'll see TDF, which is the abbreviation for tenofovir, and there's about an 82% to 86% risk reduction when patients are taking that medication in acquiring HIV. And then when it was combined with the FTC, which is the emtricitabine part, together with the tenofovir, some of the studies saw that it increased the reduction to up to 90%. And then we'll talk about the adherence, the important part with adherence to this medication in the next slide. So just like adherence is crucial to patients who are living with HIV as far as taking their highly active antiretroviral therapy, those people who are HIV negative, who are eligible for PrEP treatment, adherence is also critical to reducing the amount, their risk for contracting HIV. And the risk is not zero, but the risk with improved adherence can be as high as 99%. And we know that there are a lot of factors that can also contribute to this, to the risk. But just talking about the PrEP and taking the as its trademark name, Truvada, taking that one pill, when studies were done that people took the medication 2 times a week, the estimated efficacy was 76%, and that's how well it reduced the risk of contracting HIV. When people took the tenofovir and the emtricitabine 4 times a week, the estimated efficacy of PrEP increased to 90%. And when people took the tenofovir and emtricitabine on a daily basis, along with reducing all the other risk factors, the risk was reduced to about 1%, or the estimated efficacy. That would make the estimated efficacy about 99%. So those of us that are involved in the care of people living with HIV know how important it is and have a lot of experience in talking about adherence with patients. And so patients that are HIV negative might not be necessarily the ones that are coming to see the provider. They may or may not be accompanying their significant other or to their provider visit, but they may or may not also be accompanying their significant other to maybe a case management appointment, or maybe to speak with a peer navigator. And that just brings back how important it is for everybody that's involved in the care of the patient, and how important it would be to refer somebody to the provider, because you might hear something that the provider hasn't heard before. To summarize the PEP trials, it works if it's taken as directed. Some people were concerned that if you offered PrEP to those HIV uninfected individuals, that they would increase their risky behavior, that they would increase their behavior that would make them more at risk of contracting HIV. And that was addressed in the clinical studies, and to date, there have not been any noted increase in risky behaviors when patients were offered PrEP. It's important that people who are HIV negative be offered PrEP. So HIV needs to be ruled out. So you could, an HIV test is one of the first tests that needs to be conducted, because if you have a person who is requesting PrEP and they are actually HIV infected, then you're not helping them by only giving them, it would be like a partial HAART regimen, and that could lead to a resistant virus. To date, emtricitabine and tenofovir appear to be well tolerated and appears to be safe across many PrEP studies. Another part of the risk assessment is, in addition to the HIV test, is for the HIV uninfected partner, the partners that's going to be receiving the PrEP. They also need to be tested and treated for bacterial STDs. So people who are coming in for treatment of STDs on a regular basis should be offered PrEP. It could be one of the flags that signals that maybe your patient is trying to achieve a pregnancy or doesn't have access to effective contraception. If you know that your patient has a high number of sex partners, or if you know that your patient has an inconsistent use or does not have a history of using condoms and they tell you that. Also people who are commercial sex workers and people who live in an area or in a network of associates with a high prevalence of HIV would be candidates for PrEP. Again, on this slide, we talk about the importance of a documented negative HIV test, making sure that patients are aware, as Saniyyah had explained to us previously, of the signs and symptoms of acute HIV. And so if you have a person who has an HIV negative test, but they have signs and symptoms of acute HIV, they might need further testing to see if they indeed have been recently infected and maybe are in that window period. People who are thinking about accessing PrEP need to have a normal kidney function. They need to have documented hepatitis B titers, and if they don't have immunity to hepatitis B, vaccinations are recommended. And that is important because emtricitabine and tenofovir also treats hepatitis B. So if you put a person on PrEP with tenofovir and emtricitabine, and they have an underlying hepatitis B infection that you don't know about, and you put them on that medicine, and then they say they move on and they are not in that relationship anymore, they're not at risk for HIV anymore, and then you take away that drug, they could get a flare in their hepatitis B. So it's important to know their hepatitis B status, and if they're not hepatitis B, it's important to offer immunization. So these are some tips for providers, and we, in the interest of time, we'll kind of move a little bit more quickly through these. I will point out a CDC website that has more detailed PrEP guidelines. People who are on PrEP should be monitored every 3 months initially, and then after they've been stable for a while, some providers do monitor them every 6 months. This slide shows some reasons for discontinuing PrEP. And in our, for the purposes of our webinar, after the pregnancy, if it has been achieved, then some partners may choose to discontinue PrEP because they will go back to using condoms. So what about the people that are not ready to conceive a pregnancy just yet? Let's say you screen them and they're not ready yet. There are many contraception options for them. We always strive for dual protection. So regardless of the contraception option that you choose, you will want to make sure that they are also using something that is a barrier protection so that it protects them from the risk of HIV as well. HIV positive women can take most of the hormonal contraceptions, and I've listed them here. These are the non-hormonal contraceptions, and these provide a barrier protection. And I've highlighted the spermicides because spermicides are not recommended. They are available, but they're not recommended because they can be increased irritation in the lining of the vagina and actually increase the risk of acquiring or transmitting HIV. Listed here on this slide is the permanent contraception method for those individuals who are done with their family planning. And then I want to bring attention to the link on this slide for drug-to-drug interaction. For women who are on ARV therapy, it's important for providers to access drug-to-drug interactions because there are some with the hormonal contraceptions. So Saniyyah, let's, in the time we have left, maybe we could finish up the case discussions.
Yes, very quickly, I just wanted to mention, I was hoping that we can discuss it with the participants and get their input, but because we don't have time, I'll provide my email address in case you want to send me any questions. But for our first case where the male was infected and the wife was not infected, I think that it's very important to get the viral load of the patient down from 9,500 to undetectable level, and also get his CD4 up to above 550. That's in the recommendation. um, like we said, donor sperm is an option for this couple. Sperm washing is an option. However, they did not have insurance and they did not have money, as well as the wife did not have the insurance to be able to be seen, and she has to find resources and get a hospital card, city contract card, in order to be seen by her primary. We recommended for this woman to get on Truvada for PrEP, and she needed prescription from her provider, and then Gilead was company was gonna provide the medication for free for this couple. Um, just a caveat, the PCP provider refused to write the prescription for Truvada, and we could not see her in our clinic, but we are working on that now because she needs follow-up for labs if she's on Truvada and make sure that she's okay. For the second case, the female was infected and the husband was not. So she was undetectable. However, she was on Atripla, so I had to change her from Atripla to a non-efavirenz medication containing regimen, actually. Put her on Reatazno with Truvada, but you can choose any other option. And the other thing is that I had to teach her to check her temperature and recommend that she gets the ovulation kit, see when she's ovulating, and make sure the husband does the ejaculation in a cup, and discuss with her how to get the sperms and inject them near the cervix, in the uterine cavity. So if she wants to get pregnant that way. And she has an OB, so she's gonna go see the OB also as well. So these are my cases. And like I said, if you guys have any questions, please feel free to email me. These are some resources, brochures on conception and conception counseling from the CDC. You can access that. Plus, there's some provider checklists that the CD provides on their website that the providers can use, or actually the case managers also can use in asking questions and finding out where to proceed from there. And these are our references. And I thank you so much again for attending this webinar.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PrEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.